Everybody, good afternoon. My name is Garrett Schmidt, and I'm the CEO and Managing Editor for VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by Syntax, which is a Lightbeam company. And today's session is called The Missing Layer in Value-Based Care, Turning Performance into Financial Truth. We've got a lot of great information to cover today. But before we get started, a few items of note, just some housekeeping things. We are going to have a time for some Q&A towards the end. So we would love to hear from you. If you have a question for either of our speakers, which I'll introduce in a second here, go ahead and use your control module that has a space specifically for questions. Drop yours in there at any time. You don't need to wait until the Q&A to do that. We're going to get to as many as we can. We do, again, have a lot of information to cover. So if we don't get to yours for some reason, don't worry. Someone will reach out and make sure you get your question answered via email afterwards. Also, the session today is being recorded. So what's going to happen is when we conclude, maybe about an hour or so afterwards, you'll receive a link via email to where you can see the recording. You can also share that with colleagues and friends. We hope that you do. And also, you'll be able to download the slides there at that link. And again, we'll get that to you about an hour after we conclude. So let's see. Oh, and finally, today is a traditional webinar format, so you don't need to worry about muting your microphone or turning off your camera. We can't see you or hear you, but we are glad that you joined us today. So without further ado, I want to briefly introduce our speakers today. With us, we have Ms. Rachel Jones, and she is the Chief Executive Officer of Syntax, which is a new division of Lightbeam Health Solutions. And then we also have Ms. Emily Walker, and she is the Chief Analytics Officer of the Syntax division. So I wanted to welcome you both. Great to have you.
Thank you. Thank you. Great to be here, and thank you for the opportunity. We're excited. So we are like to jump in. I think I'm fresh from Vive, and so this topic of value-based care has been on my mind all week and all last 25 years, honestly, but particularly all week as we see so many organizations who are grappling with trying to respond to the ever-changing landscape of value-based care. We want to jump right in and talk a little bit about our experience in this space and what we've learned in leading value-based care organizations and teams, and now launching this platform and working with Lightbeam Health. But before we do, we like to always figure out who we're talking to and who's in the audience. So we've got a couple polling questions that I think Garrett's going to pop up and share with you all, and hopefully we'll get some feedback on who's in the audience.
All right, so you should see this on your screen here. And the first question is this: are you currently in a value-based care arrangement, like P for P, shared risk, upside, downside? By the way, we're going to have a couple of these, and this is anonymous, so feel free to participate. And we're going to show the results here shortly. So yes, no, or not applicable.
Okay.
You're just here to learn. So
Awesome.
The results are coming in. And we'll give this another 10 seconds or so.
Yeah.
And we'll show you the results here. Okay, I think most of you have voted, so I'm going to shut it down in another 5, 4, 3, 2, and 1. All right. Rachel, you're able to see the results. And would you mind reading them out just in case folks are calling in?
I am happy to read them out. So we had 61% of votes. As a good analyst, I have to always tell you the baseline. So we had 61% of folks voted. And of that, the majority of folks are in some type of VBC arrangement, 64% of them, so 16%. And then we had 2 who are not. I will say not yet, maybe. And then we had 28% or 7 who were not applicable. So the second question, when you're ready, Garrett.
All right, I'm going to pull this one up as well, same style as before. You should see this on your screen momentarily. There you go. If not, what is holding you back?
So the 2 of you who said no. Why not? That should be a fast one. Okay.
Okay, is it you haven't seen the value? Is it that you're still trying? And again, this is if for those of you who maybe have not are not in a value-based care arrangement, is it because you haven't seen the value? You're still trying to understand value-based care. You don't feel ready yet.
A pretty broad range that we had as options that counted as VBC. It's the full spectrum. So
yeah, Yeah.
I think most folks have the opportunity to be at some level of participation. And so what's holding you back from being at the kind of fully risk appetite, hungry, ready?
Yeah, and again, this is anonymous, so feel free to participate. All right, I think most of you have voted at this point, so I'm going to go ahead and share the results here in another 5, 4, 3, 2, and 1.
Oh, nope, they went
Oops.
away, but I think,
Oh, here, hold on. Let me see. I think I
can you pull it back?
accidentally.
Okay, perfect.
There we
Yeah,
go.
so
Are you
it
able to see
looks
it?
like we have a pretty decent split of the folks who voted. And again, these are folks who would have either not been fully engaged, as Emily said, or haven't been engaged at all in any kind of VBC. There's a mix between haven't seen the value. I'm actually really happy to see that's the lowest amount. 25% of you said that, of the folks who answered. And then the other two big chunks were still trying to understand VBC or planning to join one soon. So for the folks who are planning to join one, we love to see it. We hope that today's webinar and conversation gives some additional context and confidence behind what's out there to help on that journey. And for folks who are still trying to understand, we understand that. We support that as well, and would love to see how we can help shed some additional light and perhaps be a resource as you continue to sort of wade your way through the murky waters of VBC. So with that, we'll return back to our presentation, and I think you all can see my screen. So a bit of context, and again, I'm fresh off of attending Vive this year. The mood at Vive was very different this year. There's a lot of really hard conversations around ROI and around margin and around is the juice worth the squeeze. And I think for those of you who said you haven't seen the value, I totally understand that perspective. I think that we have moved beyond the experimental phase, at least I hope so, in VBC, even though we have different models coming out, it seems like every year or two from CMS. Conceptually and fundamentally, value-based care as a principle of reimbursement is here to stay. I don't think anyone's going to argue with that right now, that there's the appetite to transfer risk or shift risk or transfer accountability direct to the point of care physician, and the folks who are responsible for that, those decisions need to share in both the upside and perhaps even the downside of those outcomes, right? We're seeing expansion across all lines of business. If you're following the healthcare Center for Payment and Action Network, or HCP Land, they released their study for 2024 results, I think Q4 of last year, if I'm not mistaken, Emily. And it's eclipsed now, right? As a whole, alternative payment model programs have gone beyond, I think it's like 63% of all reimbursements flowing through some sort of APM dollar. That's the first we've seen that sustained. Majority of the healthcare payment dollar is going through a value-based care program. There are certainly variations by business line, right? Medicare Advantage continues to lead the pack. Commercial is a bit lagging, and then Medicaid, I think, is emerging as like a new accelerator in this space for sure. We're seeing it in our clients anyway. But across the board, it's no longer an option. It's a requirement to be in the game, as it were. At the same time, we still kind of have these pains that persist, right? Contracts are still complex. Some of that is by design, because the nature of these programs are trying to reward the right incentives and the right outcomes. So you're going to have some complexity in measurement. You're going to have some terms that may not be the same, and certainly the benchmarks aren't the same across program type, across population type. And again, we'll talk a bit about that and how we're sort of helping our clients through that. And then we still have the fact that value-based care is quite unique in that we measure after the fact, right? So you're going to do this care today, you're going to make this decision today, and you're going to make a whole bunch of 1,000 other decisions, and you won't know how you did until maybe a year, 18 months later, when that performance is evaluated. That's unique. That's a scary place to be, especially talking about the R word, the risk word, right? And when you think about, how do you prepare an organization for that, and how do you actually know what you're doing before it's too late to, course correct? That's a real challenge organizations are dealing with as they grapple with value-based care. So we know it's not going away. We know the metrics are unique and different, and the measurement is also unique and different. And yet and still, more and more organizations are being asked to take on risk, and they don't always have the right tools or visibility into those calculations, and teams are under pressure to produce positive outcomes, positive margin, positive revenue. So this is more than just an analytics challenge. It really is a contract design, risk management, and even governance and execution problem that we see that we're facing in the industry. So Emily, as you think about all of that, right, where do you see organizations really thinking about the break or the failure points in value-based care?
Yeah, I think I was actually just on a call today with one of our clients talking about exactly this. So what we've heard pretty clearly across the board is that our clients don't have a hesitation about value-based care. It's how they deliver care today. It's really just a frustration and kind of not understanding or not having visibility independently into what's driving that performance. And so when you are negotiating an arrangement or you're in an arrangement and you've just had really limited exposure or limited knowledge as to what does this mean financially? What's that forward modeling, that projection look like? It's kind of, you're going in blind is what one of our clients told us. I feel like we're going in blind. And as we work with them, it's really a matter of how do we use something? How do we approach this with some assumptions, with some performance modeling, something to give us a feel for what are we getting ourselves into? And performance gets validated, then we're trying to use numbers that payers provide, payers that might be viewing this later or have access to it. Just a little plug, access to data and visibility. It doesn't always have to be the detail. It's just a matter of having access to summary data. You're asking providers to take on risk. You need to show them something, right? You have to give them some insight into that. And so using payer numbers that aren't fully trusted, not having confidence that you're going to get payer numbers at the end of the day, and yet the payer's the one writing the check. That's one of those kind of challenging components. Other areas where clients we've talked with who are kind of a little slower to taking on the risk is that it increases too quickly, right? You go from 0 to 100. Literally, one of our clients we were working with this week is going from 0% to 100% in 1 year, and that feels like it should be doable, and yet that's a lot for practices to take on who aren't in risk today. So having the ability to forecast, having the ability to see how you'll course correct if things are going sideways, how are we going to fill that gap? I think providers are really interested in working on that space and being successful in it. But knowing how to do it and being able to see it along the way have been huge barriers for pretty much every client we've worked with, and certainly providers that I've supported in the past. So I don't think it's a capability gap in analytics talent necessarily. Some organizations, they don't have that resource, but it really comes down to a tooling gap, right? How are we not seeing this data? How are these contracts actually translating into risk terms? And what do we do about that, right? How do we govern that as an organization? Not all providers are the same. They're not all risk ready, right? They have different and differentiated needs. And I think it's really important that as payers and policymakers are kind of thinking through, how do we roll these programs out? It's not a one size fits all, even though operationally that's a lot easier to execute. A one size fits all model doesn't make sense for financial modeling. And that's something we've seen pretty universally.
So I think if I was to sum up what you're saying, and it's exactly the title of our session today, we've done a really good job in population health, right? And saying, here are the quality metrics that matter. Here are the things to measure from a utilization, readmission, chronic care perspective, rising risk, coding accuracy perspective. We know what that looks like, and we continue to do well in that space. We also know at the end of the day what we're paying for in terms of hitting those metrics or not, making those savings happen or not, right? What's missing and what has been sort of the Achilles heel of value-based care execution is that contract intelligence layer. It's connecting those financial dots, those operational dots to what those clinical interventions are. And this is really where we see the unlock happening, right? When organizations have that perfect golden triangle of financial, operational, and clinical coming together, and folks can actually translate their population health initiatives in a financial way, right? That's when you start to see confidence at the contracting table and organizations really being empowered and owning their value-based care journey. And that's really what led to us sort of being in this space. Emily and I didn't share our full backgrounds, and I'll invite Emily to do so as she kind of covers the next topic. Is both of us led organizations in this space for a long time. I led health economics and value-based care organizations at Health First in New York, as well as Anthem, now Elevance. I was part of the group that developed the initial total cost of care pilot and rolled that out, starting in 2 markets and eventually across the nation. And Emily will tell you about her experience, both in the hospital system side and the health plan side as well. And what we saw was this gap in constantly working with providers to get them on track or to get them successful. And they could do all the right things, but from a gap of understanding what the program design elements were and what the actual contract said, when it came time to payment, there was a gap, right? And that really created a lot of frustration in the clients that we worked with. And so Emily, talk a bit about sort of how we approach the build of Syntax and how these 3 pieces that we deliver really sort of change the landscape and the dynamic for folks doing this work.
Yeah, and one of the things, so we took this as like a personal challenge in building Syntax, and I'm an actuary by training. I worked 20 years on the health plan side of the house, starting at Geisinger and having the opportunity to move to Elevance and work on the national program. I've been in the VBC space that entire time, ultimately having the opportunity to work at provider-led organizations at the national payer level, and have had as many conversations with providers as one can and not completely be discouraged on their behalf that some of these arrangements don't make sense. The key thing that I recall, especially within my experience at Elevance, was just sort of recognizing when I'd get approached by one of our network leads and they would say, this provider did all the right things. They did everything we asked them to do. All those frequent ER visit members, they contacted them. All readmissions were down. They still didn't get a check. Why didn't they get a check? And the answer was that I had to give was that's not the program. That was not the contract, and those were not the terms. And ultimately what we focused on with Syntax was, how do you build something that fits in the applicable sort of way that we did work, the way that we monitored programs and informed our financial teams what we thought the payments were going to be, versus the kind of ongoing monitoring of these arrangements. And so there's 2 parts to our value-based, more than 2 parts, but 2 main parts I'll call out. The first is in that contract modeling. And so when we were looking at building Syntax, it was, how do you model these different arrangements with all the various terms and give a good sort of estimate of where we think performance will be. Now we have something to compare against, right? An expected value. And then as we're measuring performance, we're saying, okay, what are we going to observe? Is this tracking as we expect or not? So some key things that were important for me and important for our clients as we were building this is to have views that would support board level decision making. We wanted to be able to give some estimates of what we think a final payment would look like. What's the total earning opportunity? What's the maximum earning potential is what we call it, versus what's the observed year to date? How are you tracking towards that? What are the reasons that you're tracking towards that? And what can you do about it? With a number of our clients, if they're in downside arrangements, we're looking at helping them. If they're tracking negatively, how do we mitigate that risk? What are the ways that you can minimize the downside component here so that you are as proactive as possible in that financial space? And that way, as you're talking to your board and you're handing off kind of conversations, you're saying, we know we're in this, we're in maybe, kind of underwater. Here's what we're doing about it. Here's the action we're taking, and it's going to have this impact because we understand our contract. So it's really important for us that tactically you have information that's going to help you make that decision. And then the other piece that we focused on, this is something that there are some, the way the economics and kind of math of these arrangements works is it's multivariate calculus, right? I loved multivariate calculus. I'm one of the probably few people who do, but it is a very sort of variable way of calculating what's going to happen. And so you could be doing poorly in one area, but still be successful in another. And it's important to have that full spectrum view. And that's one of the things that we really needed to focus on when we were building this, was allowing the system to sort of go through that process, do those adjusters, do those calculations, and show us what's the full picture here. And so being able to have a grade, being able to sort of know what happens if, we improve in this area of pharmacy, or we have stronger referrals with our specialty network or other, right? Whatever those other strategies are, we can show that financial impact in that what if world. And I think the last thing I'd call out here is that this was really around how do we focus on actionable information, not just some, I love a dashboard as much as the next gal, but definitely being able to not just look at new reports, but actually have something you can do something with. You can take an action, you can make a decision, and you're not kind of a victim of circumstances. And so again, like with the client we were working with today, the conversation was, okay, make this change here. It has this impact over here. Here's how it plays out then in your value-based arrangement. So if you're negotiating a new fee schedule, an increase in that rate, what is that going to look like on your incentive contract? Because they're connected, they're all related. And so what we've been working with our clients on is giving them visibility of that full sort of triangle of experience that's happening with their value-based arrangements.
And I think what we're ultimately calling out here and trying to sort of, be a bit disruptive with this new category of analytics for value-based care is actuarial intelligence, right? Really calling out the fact that it's a discipline. It's a science that goes into predicting risk, predicting performance in a responsible way, especially in the era of AI when, a lot of different models are being thrown at stuff and folks are kind of saying, hey, this is a brand new shiny object, go pay attention to this over here. We want to sort of bring back that radical practical approach to the math of it all, and really make sure that you can follow the order of operations in a value-based care contract through an approach that's disciplined and fact-based and backed by this actuarial rigor. And that's why we call it actuarial intelligence, right? It's a different layer of analytics that goes beyond just looking at trends and broad numbers and kind of back at the envelope math to really saying, if I'm taking on a risk for something, I need to really understand what that risk looks like and how all these different levers can impact that, which is really why we're so excited about our partnership with Lightbeam. We started this company 3 years ago and had a lot of great opportunities to grow and work with clients directly in this space. And Lightbeam's been around, I think at this point, almost 15 years, really strong in the population health, data infrastructure, care management, and a whole host of other pieces that impact point of care and quality decision making. They didn't have this actuarial piece, right? This missing layer piece. But so many of their clients can benefit and are benefiting now from the result of us coming together and offering that end-to-end capability and having that single source of truth. So really, when you think about how value-based care operates, there is a workflow. There is the strategy and design and the modeling piece. There's the negotiation and the actual contract governance and portfolio management piece. And then there's the monitoring and sort of reconciliation piece, right? Where we want to now be able to have a conversation is, as you go end to end, what is your capabilities in each of these sections? So if you've got one slide from this entire presentation, this is the slide that I want you to sort of take and compare to what you're doing today in your organizations. And almost so as a checklist, go through chevron by chevron and say, hey, how are we approaching program design? Are we just reacting to whatever the payer says? If you're a provider, if you're a payer, when's the last time you dusted off your model and looked at, are you actually getting the results that you wanted to get from this program? Is behavior changing, right? Are you improving costs and quality outcomes that you thought you would with this program? We saw a lot of times where we would have a program in place for a couple of years and you kind of see this drop off on performance that's kind of leveling off. So you kind of go back now and say, okay, what do we have to shake up to start to get the incentive behavior change that we want to see? So as you go sort of chevron by chevron, right? How is your program design shaping up? What are you doing for contract modeling? Are you still using spreadsheets? How's that working for you? right? Is that limiting in your ability to really be flexible and to automate this process? Do you have death by 1,000 cuts of version control nightmares, trying to keep up with which version of the contract is the right one that you're trying to negotiate? How is your data? I know that we have a lot of data in healthcare, but is the quality serving your needs? Can you trust those numbers? Are you having a war, sort of a tug of war between payer and provider with trying to figure out whose member is right, right? Those are types of things that when you think about the end-to-end capabilities for value-based care, if one of these pieces are missing, that's where you start to really see friction in your value-based care program, and why folks will sort of throw up their hands and say it's not working. It's usually because one of these chevrons are missing, right? You have a contract, but you lack insight into your performance until the very last minute, and it's too late to change, right? Or you get a payment result and you're not sure if that's correct, and you have no way to validate and audit for yourself because you don't have these tools. This is what we're super excited about bringing now into the Lightbeam conversation, and really helping to connect the dots all the way through, from strategy to contract modeling to reconciliation, ultimately improvement. Because when done right, value-based care truly is a cycle of continuous improvement. You don't just, throw up your hands and you're done. You're always learning, always iterating. As Emily just said, our clients that we work with, every time we're going through their contracting cycles, it's not just here's how much you earned or will earn. It's now how are you going to improve that for next year, right? This is what you did this year. What's the plan for next year? And you continually iterate. And we also see the government is doing the same thing, right? Access and LEAD are just different versions of other programs that we've seen before. So how can we sort of learn from that and continue to improve? Emily, before I turn it back over to you now to start talking about our approach and maybe give some real life examples in the second half for our audience here. Anything else you would add to this conversation around the end to end?
Yeah, I think, one of the things that's kind of easy to get distracted from is how each of these steps feeds into the next and into the next, and yet it's cyclical, right? It's this decision loop that goes on. And so when you're in the midst of a negotiation, you're also finishing a contract, like currently in a performance year. And when you're looking at the next year, you're actually still in your current performance year. And so these components overlap a lot, which does make like the tracking of this manually really challenging. And that was something we ran into quite a bit. And so I think you have kind of 3 or 4 different cars on the track all at one time, and you're having to manage each piece of those. They could be slightly different. And so it's important to be able to sort of differentiate those in that concept.
Yeah, I love this visual of cars on the track. I always thought about spinning plates. I'm not a good juggler, but I always thought about spinning plates.
I'm not either.
Trying to keep them all in balance. So maybe the second half of this, we talked the first half, high level. What are the trends? What are the concepts? What are the things you have to do this right? Let's bring this down now for the second half and talk a bit about how we actually work. Some of the things that we've been doing with our clients. And so this first couple of slides will tell you a bit about our approach, and then we have a slide that talks about some case studies and some examples.
Yeah, and I'll tell you a lot about sort of how we practically work. We actually built Syntax for practical people because that's what we are. And so really focusing on seeing both the expertise of our experience with value-based care, value-based contracting, and how that works on the payer side with provider organizations, a lot of close links there. It was really important for us to say, hey, you can't be shelfware, right? Just that software that just goes back on the shelf. People have to understand how to use the platform. It has to be useful for them, right? And help them in their daily work. And that also means recognizing that there are things that we know from our experience that we need to help on. And so advisory to us, it's not an add-on, it's part of the package. Our advisory services is the way that we stay connected with our clients and really work with them in the application to say, what's your current arrangement look like here? Let's model it together. We have some clients who are modeling their own. They need very little help and oversight, but we're always here as a call to say, hey, am I looking at this correctly? Can you give this a set of, give this a quick eye and flag anything for me that I missed, right? And so we can be backup in that case. In other cases, we are 100% involved and at the table negotiating arrangements with our clients very, very actively because they're not as confident yet. And note, I said yet, in their own negotiation of these arrangements and really being able to spot those terms that are going to be catches in the program, I'd say. I think the main thing is that, from that concept is that we're software plus embedded experience and expertise. And that's not about outsourcing anything or kind of making consultative. We're part of the team. And that's really how we look at this and how we've focused on it. And the reason for that is that ultimately that's really what it takes to actually move the needle and to get comfortable in these arrangements. So it is intentional. And you'll see this here in our kind of phased build out with risk-bearing value-based contracts, is we really do focus on this in phases. And so we don't start clients by kind of throwing them in the platform and just collecting data and saying, here you go, here are the reports for you to look at. Instead, we've got a much more, it's a very engaged process because we do a lot of conversation and a lot of communication with our clients. The first is on just kind of before contracting gets executed, what are the arrangements that you have today? What are those contracts? What do they look like? Where are their red flags? Are there red flags? How would we grade that contract based on what we've seen in the industry, based on the different programs that we worked on? And again, giving visibility into the current state to say, what are the key things working for me or against me in this contract? As part of that kind of initial phase, we're also saying, what's the maximum earning potential of this arrangement? Is the juice going to be worth the squeeze? That's the best way I've found to say exactly what that is the opportunity here significant enough to motivate behavior change? That's the economic way to say it. In phase two, we focus on modeling and negotiations. And so really looking at where are the key things, what are those financial terms that we would adjust to make something more palatable, either to help mitigate risk that's on the table or to identify where is their opportunity to see maybe more of that earnings potential on the table. So the juice is worth the squeeze. And lastly, but managing performance in period is sort of that must-do phase. I've got to know how's it tracking. I mentioned, we have that maximum earning potential. The maximum earning potential, and we'll talk a little bit about probably some specific examples. A number of our clients working on these arrangements, they've got huge maximum earning potential in the contracts. It's not probable, though. The bar to hit that number is so high and out of reach that their actual likely earning potential is closer to zero. Mm-hmm. And so when they get zero, it's not that different than what was really expected, even if the kind of earnings potential there, if it was roses and unicorns, they could get $2 million or more, right? That's just unrealistic based on some of the terms that are in these contracts. So with our managing performance in period, with our validation of results, we're tracking against those two pieces. And so we do want to be able to watch, not just do the model, do the development, help you negotiate the terms, but how's it going, right? How do our assumptions play out? What changes needed to be made so that we could see better improvement? We do that on the fly and during contract performance with our clients today.
Anything else on the validation piece before I go to the last piece here?
Thank you. Yeah, on validation. So one of the, I'm again actuary by training, and so one of the things that we just are always ready for and prepared to do is peer review. Validation and audits are like the cornerstone of all things contracting, but especially all things value-based. And that comes into play not just from a contract perspective, but from an attribution, from a rules-based logic being applied. So we actually run a model along the, basically we'll do our own version of that reconciliation to affirm the calculation that's been performed by the payer, that the provider's seeing or otherwise, ultimately being able to say, yes, this is applying all the terms of the contract. There are multiple scenarios, unfortunately. I won't name any names, all of that, but a number of times where the logic is in place, it is contracted, and yet when we run it, the system doesn't apply those rules. And so you end up getting a number that includes transplant patients, even though they're supposed to be excluded. Or where the high cost threshold was not applied across all patients. And so those kinds of validations and true ups are still necessary because these systems are still operating in a, I would say, a clunkier manner still.
Yeah, yeah. And so I think, when we look at this continuum, I want to reemphasize the point Emily made earlier that these aren't exactly in order, right? They're laid out in order because it fits the slide, it looks pretty. But a lot of times we're starting in phase 1 for someone and then having to quickly jump to phase 4 because they have a contract wrapping up and they want to review the reconciliation and sort of provide their own point of view on it. As Emily said, negotiation cycles are also cyclical, so we could be in active negotiations with a client and also thinking about how they can manage their performance for an ongoing arrangement. And really is being able to pivot flexibly and have the line of sight into all these things at one time is where the benefit of having a platform approach comes in. I know that concept might be difficult or different than what you're used to. It was for us. We didn't think a platform was even possible in this space, but we were excited to try to build one, and we were happy that we did, because now as we're having these conversations with our clients, we can press a button and be between a contract build view, right, and see how am I going to actually approach that sandbox modeling of a contract that's coming up. And then with a click, I can be looking at their dashboard of their performance and saying, hey, we're seeing a trend that your membership isn't what you thought it was going to be, so that's impacting your overall take home. Or your quality annual wellness visit is messing up your phase gating for this particular contract. It's that level of flexibility and that level of being able to pivot is what makes value-based care contract modeling and performance so challenging when you're doing it manually. And if we can get that right, if we can get to a level where it's as easy as understanding, your emails, right, and trying to just do the work every day in managing it, then we can focus the team's efforts and actually making the improvements that matter. When you're not having to chase paper and chase, undiscrete data that's not clear, and you can actually focus on the things that move the needle, that's when the work hopefully gets fun and it's less of this cumbersome, administrative nightmare to manage for you and your teams. So with that in mind, we have a couple of examples, because we like to talk about real examples and not just theoretical, that we'd love to walk you through. And then I think we're going to go ahead and wrap up and have some time for questions, hopefully 10, 15 minutes for questions at the end. To give you a chance to engage with us here. So I'll advance the slide, Emily, and if you can, hold on, I lost my slide, there we go. You can talk a bit about these examples here.
Yeah, thank you, Rachel. So this is, I alluded to this earlier, our real life examples with our current clients. It's really important for me, this is something that's ingrained in me early on, is that we pay for ourselves, right? And the way that we do that is by showing and bringing value to our clients right away. It's one of the reasons that we also start with that contract sort of value, the contract valuation that we do to say, what's that maximum earning potential? Because maybe you don't know it. You don't know what the maximum earning potential is. And so you're not sure, is this worth it or not? So with MCR as an example, MCR Health is one of our clients we started working with a year ago.
Yeah, like a little over a year ago.
They have been a fantastic partner. This is a CHC and FQHC in Florida, and they have a fantastic, one of the best quality programs in their market in the state of Florida, and they have been very, very engaged. They deliver value-based care whether they're being paid that way or not. That is just their mantra. It's what they do. And it was really a partnership here, was being able to look at with them the evaluation of multiple Medicaid and commercial contracts. They had a number of commercial exchange contracts that they were part of, and to say which of these has kind of the best opportunity for us. What's going on? What are the questions we should be asking? We don't know what we don't know. Can you help us figure out what we don't know? And so in working through this, what we found was a number of contract structures that really was limiting the earnings opportunity for the organization. And so what were some of those terms that we could incorporate that would help them kind of see that better earning potential. They were also part of an expansion effort into new lines of business, and the offer on the table was take on risk right away, right? Dive right in. There's no data for that, no history, no historic performance to bench against. And despite the best efforts of the payer partner who was involved in that arrangement, there wasn't much they could disclose either. And so it was just too much risk to take on. And part of the work that we did with MCR was to sort of show that value. What's the maximum loss opportunity here? What's the maximum gain? So that you can make an informed decision. You can say, is that risk too scary? Is it too much for our organization, or could we take it on? And we did the same in other markets in the Medicaid space with other payers, with the MCR Health team. One of the things that came from that is they said, okay, we're going to do it. We're going to go in. We're going to do this new negotiation. And our discussion was, okay, you have these 3 ways to mitigate this risk, right? To mitigate the downside, should you find yourself in it, here are the steps we're going to take. And we've done an at least quarterly review with them to track how's it going and what are those actions that are being taken, what else can be done to mitigate that downside risk. And they've managed to kind of work on that to the level of, I can see in the near future, they'll have finalized that arrangement. And depending on how IBNR plays out, if they're in that loss position, they will have almost mitigated the entire loss, which is pretty spectacular. Our PanCare partnership is the one I alluded to previously, working with them on an arrangement that boasted a very high earning potential. There was a lot of opportunity on the table, upwards of $2 million of earnings. But in order to get it, you had to be 4.5 stars. They were not close to 4.5 stars at that point. And getting there within a year even is statistically impossible, basically. And so the earning potential there was not juice worth the squeeze. And so we were able to help them redirect to an arrangement, a different payer contract that actually incentivized them for improvement, right? So progress towards that 4.5 star goal. And so they were earning something that was still beneficial to them as an organization, but it wasn't an all or nothing type of term. And so they were able to kind of move in that direction. And we were able to partner with them in the discussions with the former payer partner to basically talk about how that looked, right? Was that the intent? They were very engaged. They wanted to be good partners, but wow, that's a high bar. What can we do instead? And so that's still a really productive partnership and payer relationship with PanCare. So definitely excited to kind of help them sort of triage, right? How do we focus our attentions here? You can't work on everything. So how do we pick the programs that are going to be worth the most to us? Mm-hmm. And lastly, is probably my favorite one, right? So we've worked with Brevard Health for the longest. They're our oldest client, longest client, I guess I should say it that way. And when we first started working with them, they actually already had a pretty good feel for what they were doing in the value-based care space, but there was something missing. They had just like a gut feeling that something was off with one of the proposals that they had. And they learned of us and reached out and were able to verify that kind of what they were seeing as this proposal was off. And really, they were probably better off going directly to the payer themselves, because what they were doing was so significant to the proposal that they were receiving. And so we ended up kind of working with them on those contract strategies and terms, and then also being able to support them in the next phase. So as they're thinking about those other contracts that they're part of, because they had their own portfolio of value-based arrangements. By working with us, they were able to kind of build confidence and know the words to say and know the words to listen for, to say, is this good for us or not? They were able to, within months, go and negotiate their own cap rates, their own new value-based incentives. I mean, they were kind of cooking with gas right away, and have since added over $26 PMPM to their value-based recurring revenue. So that's earnings potential and achieved revenue, which is for them significant.
Yeah, it was real dollars and real cents, and a real impact to the bottom line, especially in a challenging reimbursement environment. Mm-hmm. When we talk to that CEO, he's always very effusively grateful about the ability to have some control of their own destiny from a perspective of these value-based care dollars. I want to just capsize 3 takeaways from this slide. This is the other slide that I think is really important for you to pay attention to in this presentation. The first is that sometimes it's not about how much revenue you can earn, it's how much risk you can avoid before you're ready, right? And then the idea of sort of minimizing risk exposure is a conversation we don't have enough with providers, and we're trying to really encourage payers to have that transparent, open conversation to say, yes, the bar is high, and yes, we expect that you're going to be changing, MLR outcomes and cost outcomes, and it may take you 2 years to get there, right? But before you sign up for risk, let's talk about what that path looks like and how we can mitigate that risk. And I think that type of sobering, level-setting conversations is sometimes overlooked in terms of being nice and trying to get the deal done and being in the signature. And that is what creates a lot of that mistrust on the back end, is when folks think they're shooting for something that's achievable and it's not, which is the second point, which is part of this conversation that at least we see our value is surfacing intent. You'll be surprised, and maybe you're not surprised, how many times we'll share with a contract conversation and we'll say, hey, was this the intent of this particular measure or this particular term? They're like, oh, no, we didn't actually mean for that. We just thought so-and-so. And so what I hope you're hearing from us is that we don't see a good guy, bad guy. We don't see an enemy in this situation. We firmly believe that value-based care is a partnership between payer and provider and patient, right? And when done well, all 3 get the benefit of being a part of this ecosystem, which rewards the right outcomes, the right cost, and removes waste from the equation, right? And it's right patient, right cost, right time, right? And so for us, the transparency is not about a gotcha. It's about how can we clarify intent and align to make sure that what you expected to happen and what you meant to happen is actually going to happen, which is the last point is, when done well, both sides are able to really enjoy the benefits of that, right? If you're a provider, that should look like increased earnings for your organization that's not tied to fee-for-service, that's not tied to a reimbursement schedule, it's tied to your ability to drive positive outcomes. If you're a payer, that should look like improved cost profiles, improved member engagement, improved quality outcomes for your members that you serve. If that's not happening, you're likely in a very poor contract design, and we should take a look at that, because value-based care is about those things, about moving the needle on all those things together, is what we're all here for, hopefully, if you're in a value-based care arrangement. So with that, again, I want to just start to wrap us up a little bit here. First, I'll say that if you've been tracking with us so far, and hopefully you've been tracking with us so far, if you were one of the folks who said you haven't started yet, or you're in it, but you're not sure what you're in for, I want to say to you, you don't have to eat the elephant all at once. You don't have to boil the ocean, pick your idiom. You can start where you are with what you have, and we can go from there. So oftentimes, the conversations that we work with our clients on is just, let us take a look at your contracts. Let us just see what you're working with, and start to see if we can make some incremental improvements, or at least help you understand what's possible in your arrangements, and kind of work from there. We don't do a big bang. We don't try to hit a switch and all of a sudden you're doing something different. It's a thoughtful, measured approach. It's one that recognizes that you have day jobs and you have programs that you have to manage, and your teams have day jobs. So how can we sort of take this journey with you, and get you, number 1, clarity, number 2, confidence. And again, really excited about the opportunity to partner with Lightbeam Health and bring all of these pieces to scale, which is really where we see the sea change happening in the overall ecosystem of value-based care. So with that, I think I'm right on time for about 10 minutes of questions or so. So I'm going to turn it back to Garrett to see if we have any questions out there.
All right. Well, thank you, Rachel. Yes, we do have some questions. And by the way, if you do have a question for either Rachel or Emily, use your control module and go ahead and drop that in there now. And there's a place specifically for questions. We're going to get to as many as we can. If we don't get to yours, though, don't worry, someone will reach out via email. All right. Well, in no particular order, let's go ahead and dive in here with this question. What is the biggest mistake payers are making, in your opinion?
I'll start with this one, Emily, and certainly you to jump in. I think, and mistake sounds like, again, we're trying to name and blame, and I don't think that the game is blaming, right? But I think it's an oversight. I think that because everybody's so busy and everyone's trying to get things done with less, we make these broad assumptions, and we do the work to say, hey, here is the contract design model, and then we just hand it off, right? And if we don't take a pause to actually explain the assumptions that we're making, to say this contract, it has the ability to earn this if all these other things are true, right? If membership is this, if quality is this, if cost is this, and we're making the assumption that these 4 things will be in place, and here's the definition of performance, and here's the projections that we're making, et cetera, et cetera. When that conversation isn't had, and it's not an equal-sided conversation on both, where both sides have the same information, I think you run the risk of friction. It's almost your guaranteed friction, because you're going to have a situation where someone thought something and the other person didn't think that thing, and now you're trying to argue the past versus focusing on how you can improve the future. Emily, anything you'd add to that?
I think the piece I would add is sort of what we started with, right? It's transparency is how we rebuild trust, and payers, especially that are writing the checks, it's their check to write. There's a transparency component to that says, this is how we got here. I'm a big fan of show your work, right? Like my 5th grade math teacher drilled, like, you get partial credit because you show your work. And so show your work is really valuable, whether it's a payer, it's a provider. It says, this is how we got here. This is the number that we got to. And we've seen a number of payers that have really leaned into this space, and they're really strong in this. And others that I think they're distracted, I would say. Again, not to point fingers, not to lay blame. It's really just a matter of transparency here is the way you rebuild trust with providers that, quite frankly, the trust is very, very broken. And I think if we're being honest about that, anybody who's been in this space and sat at the table, either on the payer or provider side, you've seen it. There's not a lot of confidence in what a payer or provider are telling you about, like, what is or isn't happening. And I think it's really important that transparency is what we lean into. That means showing the math and providing those detailed data sets to do so. Just wonderful. Like the actuary to say, right?
Right. All right. Next question here is, do you feel like the providers are ready for downside risk?
You want to take that one first?
Yeah, it's my favorite answer. It depends, right? It so depends. It's value-based care is so differentiated. Some providers, I think, really want to take on risk. We know a number of them that we've worked with who are really ready, and they're not. They shouldn't yet, right? Because they're too small, or it's too volatile. It's still kind of an unknown about their patient population, and so very, very excited to take on risk may not be ready yet, right? And then there's the alternative where it's somebody who's saying, no, I don't want any risk, and yet they're performing really well consistently. They have consistent good performance. They're technically like leaving savings dollars on the table. So, hey, how do we do that, right? How do we highlight that opportunity? I really think it depends. I think providers are ready to progress to taking on risk with the right guardrails in place, because providers are not insurers, right? Insurance companies manage risk. They're supposed to. That's the job, right? And so allowing payers and providers to kind of like do that work with payer taking the right kind of oversight step of risk and a provider leaning in when it makes sense from a volume and consistent performance perspective. Yeah, I think they're ready, but it depends.
Okay. All right. Next question here is, how does value-based care contracting actually drive earnings?
Well, the devil's in the details, I guess. So you could, if you like to say, the God's in details, depending on which phrase you like, the more positive version or the less version. But I do think that from an earnings perspective, there's a couple of different levers that we see most commonly. The one that's kind of like the layup at this point, or table stakes, is risk accuracy for contracts that are risk adjusted, because not every population has a risk adjustment factor to it. But where we see that coming into play, and you have the ability to have accuracy in your coding, it certainly impacts revenue. And if you're, unfortunately on the other side, the coin flips both sides, right? If you're too aggressive and you have inaccurate coding or overstated risk, then you face penalties, you face clawbacks, you face some bad stuff too, right? So the goal here is accuracy, the right amount of oversight and coding for the right disease burden. I always think about this one example when I led our risk analytics team at Health First. We had a provider that said, "Oh, I didn't know you had to sort of code diabetes every year because there's no cure for diabetes, right? But yeah, you have to code it every year, right?" And so it's things that you think are no-brainers, that the education comes into place, which is really critical, that you have a education component in your value-based care programs as well. The other two, quality, which makes a lot of sense, right? The two sort of bedrocks of value-based care are quality outcomes and cost of care management. And so from a quality perspective, there's real revenue to be gained from stars and quality bonus. The stars program is being shaped as we speak, but there is certainly going to be some level of stars quality performance across different lines of business. And it can often be the difference between a positive and a negative outcome for your value-based care organization. We have many clients that may miss the mark on the cost of care piece, but they'll nail it on the quality, and that allows them to have a positive outcome at the end of the day. And of course, the most sort of fundamental one is that total cost of care management. Where we see total cost of care programs, we still have some room to grow there, I think, across the VBC ecosystem, where total cost of care is the true litmus test of value-based care measurement. But where you have that, and you have good insights into managing total cost of care and reducing spend, reducing trend in a smart and thoughtful way, versus a benchmark that, again, that's defined and visible to you, I do think that's an opportunity to create earnings. But again, all of these things at the end of the day really require thoughtful model design. It is not one size fits all. It really does depend on your organization, your population, the type of population that you're dealing with. It's not just sort of throw it at the wall and see if it sticks. It should be a thoughtful conversation that looks across these levers and really designs a program that can engineer savings before you sign it.
I'd add just one thing here, and I think that's just the kind of two pillars of the total cost of care arrangements, of value-based arrangements, sort of generally attribution rules matter, who's included and who isn't. And the second thing, the number two that's most important, is order of operations, right? How does the math flow? When does quality get applied? How does it get applied? Those are all really critical components, and they can very much change what's the dollar amount on the table.
Awesome. Yeah.
Very good. Well, unfortunately, we are out of time. And I wanted to thank you, Rachel. Thank you, Emily, for a fantastic presentation. There's a lot here. Again, we're going to be sending out a link to the recording afterwards, so you can get the recording, download the slides there. I know a couple of you asked about that. A little plug for HIMSS. I think, Rachel, do you want to speak to that for a second?
Yeah, for sure. So we'll be at HIMSS in 2 weeks. I can't believe it's March already. I feel like the year just started. So come see us at HIMSS. We'll be at booth 4053 in Las Vegas. And there are two specific presentations that Lightbeam folks will be at. One is with Mike Hoxter in the Microsoft Theater booth, and that's Tuesday, March 10th. And there's also a presentation on AI and SDOH. With one of our clients, St. Peter's, and that's Wednesday, March 11th at 3 p.m. Again, these are Pacific time, I think, for Vegas time, I'll just say that. So come find us in Vegas at HIMSS if you're attending.
Wonderful. And I will be there too, so I hope I see you. Uh, let's see. Lastly, I wanted to encourage you all to head over to vbcexhibithall.com. Check out the Lightbeam virtual exhibit booth there. There's a lot of great resources that they have available. And of course, you can read up on them and what they're doing. More to come there as they're doing more and more with Syntax. And also, again, at vbcexhibithall.com in our library archive is where you'll find this webinar, along with all the other ones that we've done with Lightbeam and a bunch of other great resources and articles there as well. And then finally, if you would like to reach out to the Lightbeam team, their information is here on the screen, and there is an email address, and of course you can go see their website. Or if you would like to reach out to me, I'm happy to facilitate an introduction as well if that is easier. But I want to thank you all again for joining us today. I hope you will join us again on the next one, and we'll see you then.
Thanks.
Bye-bye now, everybody.
Thank you.